Hi everyone, and welcome to our module on coarctation of the aorta. This is a drawing of a coarctation of the aorta. It's a narrowing of the aorta that usually occurs in the thoracic aorta just beyond the subclavian artery. And this is an MRI of the chest from a patient with coarctation of the aorta. You can see that it's easy to identify. It's a very narrow portion of the aorta. Coarctation is a congenital disorder. It is not acquired. People are born with this problem, and as I said before, it usually involves the thoracic aorta distal to the subclavian artery. This portion of the aorta is near the insertion of the ductus arteriosus, and therefore it is often said that coarctation occurs in the juxtaductal aorta. And there are subtypes of coarctation that we'll talk about in a minute based on the relative location of the coarctation to the ductus. In other words, whether the coarctation comes before or after the ductus arteriosus. And the primary physiologic disturbance caused by coarctation is high resistance to flow. We'll talk in a few slides about all the problems this creates in terms of hemodynamics. You can subdivide coarctations of the aorta into preductal coarctations and postductal coarctations. In preductal coarctations, the coarctation or narrowing occurs before the insertion of the ductus arteriosus into the aorta. This has one set of physiologic disturbances that we'll talk about in a minute. The other type is the postductal, where the narrowing of the aorta or the coarctation occurs after the insertion of the ductus arteriosus. This has different physiology from the preductal type. So let's briefly review the role of the ductus arteriosus. This is a structure that shunts blood in utero in the fetus from the left pulmonary artery to the aorta. And the patency of this structure is maintained in utero by relatively low oxygen tension and high levels of prostaglandins that come largely from the placenta. At birth, the oxygen level in the ductus arteriosus rise and the prostaglandin level falls because the placenta is lost, and this leads to closure of the ductus arteriosus. Functional closure, meaning that the structure stops conducting blood, occurs in about 18 to 24 hours after birth. This is because smooth muscle constricts. And then anatomic closure occurs over the next few days or weeks. This is where the structure basically deteriorates and becomes a ligament, and then it is called the ligamentum arteriosum. So with that in mind, let's try to understand the physiology of the preductal type of coarctation of the aorta. This is also sometimes called the infantile type. I'll explain why in a minute. So in this situation, the ductus arteriosus comes after the coarctation, as I've shown in this drawing on the screen. This means that in utero, the ductus arteriosus will supply the lower extremities with blood. The upper extremities will receive blood from the aorta proximal to the coarctation, and the ductus arteriosus will supply blood to the lower extremities. If not for the ductus arteriosus, the lower extremities would be deprived of blood and oxygen, and that would lead to the development of collateral vessels around the coarctation. But these collaterals do not develop in this situation because the ductus arteriosus is distal to the coarctation and it supplies the blood to the lower extremities. So the key consequence of a preductal coarctation is that there is poor development of collateral vessels in the fetus in the womb. When the baby is first born, the ductus arteriosus will still be open. Remember, it doesn't close until about 24 hours. So initially when the baby is born, what you can sometimes see is cyanosis in the lower extremities. This is because blood is bypassing the lungs via the ductus arteriosus and going to the lower extremities and delivering deoxygenated blood to the lower extremities. But the really dangerous consequence of this type of coarctation occurs when the ductus closes. This can lead to symptoms and the baby can get very sick. Once the ductus closes, all the blood flow in the aorta has to go through that severe narrowing. Remember what I said before, collateral vessels around the coarctation do not develop in this form of coarctation. So once the ductus closes, all the blood flow has to go through that severe narrowing, and that's very difficult. There's a very high resistance to flow. This leads to a sudden and abrupt increase in afterload when the ductus arteriosus closes. This can raise the left ventricular end diastolic pressure and cause acute heart failure. The baby's left ventricle can even dilate and the ventricle can fail and the baby can go into shock. And this is all caused by closure of the ductus arteriosus. And if they describe this type of coarctation in a board question, what you are likely to see is a baby who goes into heart failure and shock about day 2 or 3 of life. And what they are going to want you to recognize is that that is all caused by closure of the ductus arteriosus. In the genetics section, I talk about Turner syndrome, where girls are born missing an X chromosome. They tend to have short stature and a webbed neck, like what I've shown on the screen here. And 5 to 10% of girls with Turner syndrome have coarctation of the aorta. And it turns out that Turner syndrome patients more commonly get this preductal type of coarctation compared to other patients. Turner syndrome patients can get all types of coarctation, but they do tend to get more of the preductal type. Luckily, the preductal type is uncommon. The more common type of coarctation of the aorta is the postductal type. In this type, the ductus arteriosus does not supply the lower extremities with blood in utero, and for that reason, collateral vessels develop. If you look at this drawing on the screen here, in utero, there's poor blood supply to the distal aorta and the lower extremities, so collateral vessels will develop. This is a good thing after birth because the baby will not go into heart failure like we talked about in the preductal type. The bad thing about this, however, is that it may not present in the infancy period. It may go undetected until adulthood, and for that reason, this type of coarctation is sometimes called the adult type. In this type of coarctation of the aorta, the lower extremities have low blood pressure. This can lead to renin release from the kidneys and salt and water retention and vasoconstriction via angiotensin II. It can also lead to weaker pulses in the lower extremities. This is sometimes called brachiofemoral delay. Basically, if you feel the brachial pulse and the femoral pulse at the same time, there will be a delay between when you feel the brachial pulse and when you feel the femoral pulse. In the upper extremities and head, however, because of these phenomena I described right here, the renin release, the salt and water retention, and the vasoconstriction, there will be high blood pressure. And for that reason, coarctation is one of several causes of secondary hypertension. A key association of coarctation of the aorta is a bicuspid aortic valve. This is a picture of a bicuspid aortic valve on the screen. Aortic valves should have 3 cusps, but in a minority of patients there are only 2 cusps. These aortic valves are called bicuspid, and they are found in up to 60% of patients who have a coarctation. Another key association of coarctation of the aorta is intracranial aneurysms. About 10% of patients with coarctation develop a Berry aneurysm like what I've shown on the screen here. It's thought that the coarctation represents a more diffuse abnormality of the vascular tree, and therefore not only do you get the narrowing in the aorta, but you also get abnormal blood vessels in the brain. So as I told you before, in the postductal type of coarctation, there isn't heart failure in infancy, so how is this going to be diagnosed later in life? Well, the only sign may be hypertension in the arms, and sometimes this disorder is uncovered when a young person is diagnosed with hypertension at a very early age. Rarely there can be a murmur in the back between the scapula. If you ever see a board question describing a murmur in the back between the scapula, they are probably talking about coarctation. There can be weak femoral pulses, as I described before, and then in rare situations, patients can develop pain with walking. This is claudication, and this occurs because there's poor blood flow in the lower extremities, and therefore the legs become ischemic with exercise. A classic finding on chest x-ray in coarctation is rib notching. This occurs because the high pressure above the coarctation causes the intercostal vessels to enlarge to carry blood around the obstruction. And these vessels bulge into the ribs and cause a finding called rib notching seen on chest x-ray. If you look at this picture on the screen, you can see the arrows pointing at white lines in the ribs. That is evidence of rib notching. Another classic chest x-ray finding is called the 3 sign. This is a bulge before and after the coarctation that looks like the number 3. If you look at this x-ray on the screen here, you can see the number 3 right here. That is the 3 sign. Now you might think that people with coarctation would be flushed in their upper extremities because of the high blood pressure and the high blood flow. You might also think that they would be cyanotic in their lower extremities because there would be low blood pressure and poor blood flow. However, it turns out that often doesn't happen, and this is because of autoregulation. Autoregulation is a phenomena of many of our tissue beds where they can modify their blood flow to maintain normal regional blood flow. So because of autoregulation, you can get normal and upper lower extremity perfusion despite the different high and low pressures. So for example, in the upper extremities there is very high blood pressure, and that should lead to high flow. However, the arterioles will constrict to limit flow to the normal level. This is a local effect. It's not mediated by the sympathetic or parasympathetic nervous systems. In other words, the upper extremity tissue beds create a high resistance to flow. Remember that flow is equal to pressure divided by resistance. So if pressure is very high, to maintain normal blood flow, you need to make resistance very high. This is done by constricting the arterioles and limiting the blood flow through tissue beds in the upper extremities. In the lower extremities, the opposite phenomena occurs. There is autoregulation to adjust for low blood pressure. The arterioles will dilate and that will increase flow to a normal level. Once again, if pressure is low in the lower extremities, then resistance must become low to maintain normal blood flow. The way that resistance becomes low is by dilating the arterioles, and the result is normal or compensated blood flow in the upper and lower extremities despite the different pressures caused by the coarctation. And finally, I'll finish with this slide and describe some of the complications that can occur, especially if coarctation is not treated. Coarctation is usually treated with surgery or stenting of the aorta, but if it's not treated, some of these complications shown on the screen may develop. So first of all, people with coarctation can develop heart failure if the narrowing isn't treated. This is basically the same thing as untreated hypertension. There's pressure overload on the left ventricle. In addition, patients with coarctation are vulnerable to aortic rupture and dissection. And then finally, these patients are at risk for endovascular infection. This means infections inside the vascular tree. It often means endocarditis, infection of the heart valves, or endarteritis, which is infection of the arteries. The reason this happens with greater frequency in coarctation patients is because the high-low pressure across the narrowing can injure the endothelium, and this is a setup for bacteria to adhere to the vascular tree. In addition, there's low pressure distal to the narrowing, and this makes it easier for bacteria to attach. So for all of these reasons, bacterial infections can occur inside the arterial system, and that's why these patients have a higher incidence of endovascular infections. And that concludes our video on coarctation.